Good morning, all. I'm Dr. Brinda. I'm here to present a case series on visual outcome and role of USG scan in subhyaloid hemorrhage following RTA. Subhyaloid hemorrhage is a localized detachment of vitreous from the retina due to accumulation of blood between the internal limiting membrane and the posterior hyaloid. It can cause a sudden vision loss if it involves a fovea. USG scan is useful for diagnosing lesions of the posterior segment when the light conducting media is opaque. The subhyaloid hemorrhage obscures the underlying retinal status, which points towards the need for imaging. This case series is to enlighten regarding the role of USG scan in cases of ocular trauma and how it alters the management modalities. Case 1 was a 29-year-old male who came with complaints alleged history of RTA, came with complaints of acute onset multiple floaters in the right eye, which increased in size on head movements. There was no complaints of defective vision, flashes, diplopia, eye pain, or pain on eye movements. There were no other relevant ophthalmic or systemic history. Patient had an orthophoric gaze with full extraocular movements. Visual acuity in both eyes was 6/6. Color and intraocular color vision and intraocular pressure were normal. Anterior segment of the right eye showed a subconjunctival hemorrhage. The rest of the anterior segment examination, including the pupillary reactions, were normal. On fundus examination, the right eye showed multiple hemorrhages. There was a dark red boat-shaped subhyaloid hemorrhage seen with the hemorrhagic tracts in the upper part and the lower limit extending into the macular region just above the fovea. There was a bright red, ill-defined subretinal hemorrhage seen below the macular area. There was a dark red, well-defined circular subretinal pigmentepithelial hemorrhage in the infratemporal quadrant, and there was a bright red, diffusely spread, ill-defined vitreous hemorrhage in the inferior aspect extending into the periphery. There were no retinal hole, detachment, tear, retinal dialysis, or choroidal rupture seen. The left eye fundus was normal. On USG scan, it showed a vitreous hemorrhage and the subhyaloid hemorrhage in the right eye with no retinal or choroidal detachment. CT scan showed no orbital wall fractures or any evidence of intracranial hemorrhage or contusion. As the patient had a 6/6 vision, the inferior limit of the hemorrhage was just above the foveal region, and as the retina was attached, we opted for a conservative management. On 2 weeks follow-up, the vision in both eyes retained to be 6/6 with a normal color vision and intraocular pressure. Subconjunctival hemorrhage in the right eye resolved. On fundus examination, the subhyaloid, subretinal, and the RP hemorrhages were resolved, with a few resolving vitreous hemorrhages. The case 2 was a 31-year-old male who presented with complaints of acute onset defective vision and eye pain in the left eye following RTA. There were no complaints of flashes, floaters, diplopia, pain on eye movements. There were no any relevant ophthalmic or systemic history. General and systemic examinations were normal, orthophoric gaze with full extraocular movements. The vision in the right eye was 6/6, but the left eye vision was 4/60. The right eye anterior segment was normal. The left eye anterior segment showed periorbital edema, ecchymosis, subconjunctival hemorrhage, and there was a grade 1 REPD. On fundus examination, right eye fundus was normal. The left eye fundus showed a dark red boat-shaped subhyaloid hemorrhage seen infratemporal to the disc with extension into the macular region with foveal involvement. The underlying retina appeared slightly elevated. There were bright red vitreous hemorrhages seen dispersed in the inferior aspect extending into the periphery. On USG scan showed floating membranes arising from the posterior wall, likely due to retinal detachment in the left eye with few vitreous hemorrhages. Due to the significant vision loss and the detached retina, the patient had to undergo a pars plana vitrectomy with removal of hemorrhage, endolaser, and silicone oil implant. Following the surgery, the patient's vision in the left eye improved to 6/24. Discussion. Subhyaloid hemorrhage is caused due to the accumulation of blood between the internal limiting membrane and the posterior hyaloid. Management of subhyaloid hemorrhage depends upon the underlying disease, patient's age, duration, location of hemorrhage, and the underlying retinal status. USG scan helps to identify any vitreous hemorrhage, PVD, subhyaloid hemorrhage, RD, or choroidal detachment. Spontaneous resolution of the subhyaloid hemorrhage usually takes weeks or months depending upon the amount of blood present. Prolonged contact with hemoglobin and the catabolites can cause toxic damage to the retina and photoreceptors. The other treatment modalities that are available for treatment of subhyaloid hemorrhage include ND-YAG laser hyalotomy, pneumatic displacement with intraocular gas and tissue plasminogen activator, intravitreal anti-VEGF, and pars plana vitrectomy. In this case series, the case 1 had subhyaloid hemorrhage with an attached retina, while the second patient had a subhyaloid hemorrhage with an underlying retinal detachment. While the mainstay of treatment of subhyaloid hemorrhage remains observation, the underlying retinal status and causative pathology also plays an important role. As USG scan showed a detached retina in the second case, he had to undergo vitrectomy to restore his vision and to prevent complications of long-standing hemorrhage. In conclusion, ocular trauma is a common entity which an ophthalmologist sees on a day-to-day basis. All trauma cases should undergo fundus examination to assess the retinal status. If the media visualization is poor and the underlying retinal details could not be appreciated, a USGB scan should be done to rule out any retinal pathology. As management of each case varies depending on the retinal status, USGB scan plays a pivotal role in ocular trauma. These are my references. Thank you.
Yes, Dr. Brinda. So what is new in this study, or what is something that we don't know by now?
It was not a study, it was actually 2 cases that was
Okay, in
compared.
that case also, would you like to really give some
Actually, previously it was
message?
thought that as the hemorrhage usually resolves, the patient did not, we can wait for some time. But in various studies which had shown that the even if we wait for some time, we can later lead on to decrease in vision because of the formation of retinal ERMs, pigment changes, macular disruptions. So it is usually better to do a B scan, assess the retinal status, and if there is any underlying pathology, better than waiting and wait for management, or better to do for any hyalotomy or any surgery.
Normally, when you have such a bleed over the macula, a subhyaloid hemorrhage, normally it is not left to itself. Normally, it is treated elsewhere in an extramacular area and outside the, the important central retina. It can be left actually, but in
First
the
case, it was actually in the macular area, but the fovea was not involved, and the patient had a vision. So, after at the 2 weeks interval, the whole of the hemorrhage has resolved. So, if the fovea is involved, it is better to do for a surgical management than to wait and watch.
okay, and also in the title, just a small suggestion. You should not include a short form like RTA because it is not a universally accepted acronym. And in the title, however simple, however obvious it may look, you need to put the full form at least in the title. And you can put in the brackets RTA and you can use RTA later.